That's pretty good. Less than 5 seconds to quiet down. I'm impressed. People must be excited about this topic. I'm Bob Challoner. I think I know many of you, most of you, the President and CEO of Southampton Hospital. I'd just like to welcome you to the symposium this morning as part of our Tick-Borne Disease Resource Center. The symposium today is really for medical professionals. We will be taping it so that we can share it with other people. But I don't believe the question and answer session is taped, so that any of you, you're allowed to ask dumb questions as medical professionals. That's my way of saying that. There's a lot of misinformation about tick-borne diseases out there, and we have been holding these symposia for our medical staff and clinical staff because part of our mission is really to get you better information as well. Let me just tell you for a second before I introduce our speaker about our Tick-Borne Disease Resource Center. The Tick-Borne Disease Resource Center was really born a little over a year ago, and as a result of a lot of questions and concern from people in our communities and also our medical staff, people worried, frankly, frightened by what's going on with the sort of surge in tick-borne diseases that we've seen throughout our community, both existing things like Lyme disease, new diseases, some things that I still can't even pronounce their names, and also questions from our clinicians and our doctors and our nurses about what is this, what do we do about it? We need good information. Help us, frankly, help us get the information. So we established the center a little over a year ago with 3 real goals. The first goal is to provide good information for the public, and we held a number of events last year throughout the region to get good information out to the public. And we relied on a panel of our own doctors who've become experts, one of whom you'll be hearing from today. And we brought in a number of experts from other places, Rockefeller University, Stony Brook, and held a number of sessions for the public in libraries and community organizations here at Parish Hall, really throughout the East End, and they were very, very popular, and feedback was very good. And people are hungering for more, so we will continue to do that. We also want to provide, as I said, a second mission is to get good information out to our physicians. And we've been relying on our panel of doctors. A couple of them are here, Dr. McGintee, who you'll hear from in a little bit, Dr. Dempsey, who's been speaking, been very generous with his time. A number of our doctors who, because they're really at the front line of these tick-borne diseases, have been forced to become experts, have invested a great deal of their time researching, learning about it, and have developed quite a body of knowledge, frankly. Dr. Coolidge, another one who just walked in, has joined our panel, who are graciously sharing their expertise with all of us and all of you, and pointing us in the right direction. They are keeping us on the straight and narrow in terms of good clinically or evidence-based information. We want to make sure that the information we get to all of you is accurate, is state-of-the-art in terms of research, and also shy away from some of the fads and the stuff that's floating around out there about tick-borne diseases that frankly just isn't backed up by the science. So it is an area, though, and you'll hear from Dr. McGintee shortly, where we are learning a great deal very, very quickly. So there's new information becoming available practically every day. So to all of the physicians in the room, in particular residents who are starting their careers, stay tuned, I would say, because there is a great deal of additional information becoming available. So educating the public, educating our physicians, and then the third area that we've been focused on is navigation and helping people find help. Whether it's our patients or in some cases even our doctors have turned to us and said, I need help getting resources for a patient. We are not establishing a treatment center. That's not what we're about. We're trying to tap into the resources of our own doctors, our own medical community, and our partners in the wider world, and use the resources available to us. But we have established a helpline. Debbie Mela, who is our Director of Infectious Diseases, is here. She's been manning or womaning the helpline, sorry, Debbie. And she's been getting questions literally from all over the country. People have heard about this and have been calling in. We have information on our web, and we intend to continue to build that function and get the resources out there to help people get to clinicians, get into treatment, find the right protocols and medications that they need. And I would say we had a rip-roaring successful year last year. Not only did we lost track of the attendance, frankly. There were so many people coming. But we also hit a lot of the media and started to receive donations spontaneously at the end of the year toward funding what we're trying to do here. So it's something we're very excited about, and something that Southampton really views as a give back to our community, quite frankly. It's not something the hospital's doing to make money. It really is something we're doing to try to provide better education and help the people, our friends and neighbors who are dealing with this. Many of us, myself included, have dealt with ticks and tick-borne diseases, and it is something living out here that has become a reality of life, and frankly, hurting our quality of life in some ways, and that's something we don't want to happen. We don't want people to be afraid. We don't want people to be avoiding the area, and we certainly don't want people hiding in their houses. We want them out enjoying our beautiful communities. So one of the speakers and people that got involved with this was Dr. Erin McGintee. Dr. McGintee grew up in East Hampton. She obtained her medical degree from SUNY Stony Brook and her training in pediatrics at the Children's Hospital of Philadelphia. Following her residency, Dr. McGintee pursued subspecialty training at Children's Hospital of Philadelphia with an adult allergy training at the hospital of the University of Pennsylvania. She returned to New York in 2009, and we love it when our local kids return, especially as doctors and nurses. She returned to New York in 2009 and joined ENT and Allergy Associates, where she practices both adult and pediatric allergy and clinical immunology, seeing both patients in Southampton and in Riverhead. Her specific interests include asthma, atopic dermatitis, food allergy, and allergic rhinoconjunctivitis and sinusitis. She's board certified in allergy and immunology. Dr. McGintee is also a member of Southampton Hospital's Tick-Borne Disease Resource Center's Medical Advisory Panel, where she is the resident expert on the alpha-gal meat allergy, which is carried by the Lone Star tick. Over the last year, Dr. McGintee has been in demand as a recognized expert on this novel allergy, appearing both regionally and in national broadcast news, in many print publications, and even on the BBC. We're very lucky to have Dr. McGintee practicing here in Long Island and on our staff, and I asked her if she's starting to be referred to as our alpha gal, and you'll soon learn what alpha gal is all about. Thank you, Dr. McGintee. Please give her a big round of welcome.
Good morning. Thanks, Bob, for that lovely introduction, and thank you all for coming. Thanks, Karen, for organizing this. I'm excited to speak to my fellow clinicians about this allergy. I've been doing a lot of speaking on this allergy, mostly directed at the public, teaching people about the allergy, and as Bob mentioned, doing a lot of media work, but I really like to sometimes dig into the science behind the allergy, and who better to speak with about that than my fellow clinicians out here on the East End. So, before I start, I just would like to acknowledge a couple of doctors down at University of Virginia who have done a lot of the research on alpha-gal allergy and have been very inclusive with me in terms of involving me in their research endeavors and helping me with data collection and Those doctors are Dr. Scott Cummins, who also provided me some of his research slides for this presentation, and Dr. Tom Platts-Mills, who's a senior allergist and immunologist down at University of Virginia. I always like to start speaking about the allergy with a case presentation. And this is a patient who presented to me in 2012 with a relatively typical story for this allergy, but quite honestly, I could substitute almost any of my patients and it would be a very similar story. So I actually first saw this patient in August of 2012. She's a 65-year-old female, presented with a 1-week history of this pruritic rash on her bilateral lower extremities. And I'm not sure how well that's projecting, but I'm sure many of you recognize that rash. She had been seen by her primary doctor, diagnosed with chigger bites, and she came to me thinking she was having an allergic reaction. I confirmed that they were indeed bites, although I argued that they may not have been in fact chigger bites, and we'll discuss that a little later, and sent her on her way. So about 3 weeks later, we received a call from the same patient. She told us a story that on September 10th at around 5:30 p.m. she'd eaten lamb chops for dinner, something she'd eaten many times in the past without any issue. Was completely fine until around 11 p.m., at which point she developed generalized diffuse itching, skin flushing that progressed to generalized hives, progressed also to nausea, tightening of her throat, and she was experiencing palpitations. She suspected she was having an allergic reaction, so she took 50 milligrams of Benadryl, but the symptoms continued to progress, and ultimately she drove herself from East Hampton to the ER here in Southampton, which I told her after the fact was probably not such a good idea. She made it. They treated her with the full anaphylactic protocol, or allergic reaction protocol. She got Benadryl, IV Solumedrol, IV Pepsid, and within hours the symptoms had resolved and they did not recur. So clearly she was very confused. I had her come back in the office for additional testing a week later. I performed prick skin testing, which is the standard first line of testing that we do for allergy patients, tested negative to a panel of environmental allergens and a panel of food allergens. I tested her by intradermal testing, which is a second line of testing that we do for environmental allergies. She did test positive to cat, dog, and dust mites on that level of testing. I had already been seeing cases of this allergy, so I had a suspicion that I knew what was going on. So I gave her a prescription, sent her for some blood work, and these are the results. So her total serum IgE was slightly elevated at 225, and I also sent some specific IgE testing. So even though her prick skin testing for food allergies were negative, she tested positive for IgE to lamb, IgE to pork, IgE to beef, IgE to milk, and this allergen that I'm going to spend the rest of this time speaking about today, galactose alpha 1,3 galactose, her IgE was significantly elevated at 38.9. So I had my diagnosis of alpha-gal allergy. I'm going to move into now a little bit of the background science as to how they discovered this allergy and characterized the tick trigger of this allergy. So interestingly enough, it was the oncology world that first started seeing cases of patients reacting to alpha-gal. And our friend Martha Stewart, who I believe frequents the Hamptons from time to time, actually ties into this story. The stock that she dumped during her insider trading scandal was Imclone stock. And the reason she got rid of it was because she got inside information that this biologic cetuximab was not going to be approved by the FDA. And the reason it was not going to be approved was that patients were having allergic reactions to the drug. So back in 2007, Bert O'Neill out of Vanderbilt University was seeing a high incidence of cetuximab-related infusion reactions in his area of the country where he was practicing, which was not consistent with the clinical trials on the drug and the package insert. So if you look at the actual clinical trial data, they reported an incidence of systemic reactions of about 3%. Dr. O'Neill was seeing an incidence rate closer to 20%, and some of the reactions were severe. And there was an abstract as well in the Journal of Clinical Oncology that reported a similar incidence of cetuximab reactions out of a hospital in Missouri. So he thought that this was weird, and so he reached out to some colleagues in other parts of the country, and they actually thought he was crazy because they were seeing incidence rates of 3% or less. So a group of doctors down at UVA, along with Vanderbilt and some other sites, decided to look into this a little bit further. And this is a little bit complicated, but this is just a slide. They developed an assay down at UVA for looking at novel allergens. So they could take any antigen, whether it ever had an established RAS test developed for it. If they biotinylated it, they found it would bind to a Streptavidin solid phase. And then they could perform an ELISA the same way that we do for these standardized RAS tests and get predictable results. So with this new assay that they developed, they were able to study and see whether patients were making antibody against cetuximab. So they published this paper in the New England Journal in 2008. And this is one of my busier slides, but it's also one of my cooler slides, and it kind of summarizes the study pretty well. So what they looked at was 35 patients with cancer from Vanderbilt who were treated with cetuximab. They had pre-treatment serums in the lab, so serums from these patients before they had ever even received cetuximab. And then they collected cases from a couple of other sites where there were also some infusion reactions to cetuximab. So they had a total of 76 cases from hospitals in the Southeast. Of those 76, 25 reported cetuximab reactions, and of those 25, they were able to demonstrate in 17 of them that they had IgE antibody to cetuximab prior to ever receiving the drug. So they were able to identify that the antibodies were in their serum prior to ever having any exposure to cetuximab. There were 8 patients who did not have antibodies to cetuximab who reported reactions, but 7 of those 8 patients had very mild reactions, and 4 of those 8 ended up receiving cetuximab again, and they did fine with it. Most of the reactions up here were grade 3 or grade 4 systemic reactions, so talking about generalized hives, angioedema, hypotension, respiratory symptoms, or severe anaphylaxis. The part of the study that I think is most exciting is that they also looked at some matched healthy Tennessee control subjects, and just as many, 15 out of the 72, also showed antibodies to cetuximab. They had 2 other control cohorts that were in areas where the incidence of cetuximab-related infusion reactions were low. So they had some California subjects who were patients with head and neck cancer, 3 of whom who had actually received cetuximab, but there were very low incidence of preformed IgE antibody to cetuximab in that group. And this was a women's health cohort of 341 women out of Boston. Again, they just looked at that group because they had blood, and that was an area where people were not seeing a high incidence of cetuximab-related reactions. And only 2 out of 341 showed any level of preformed antibody to cetuximab. So clearly there was a regional issue going on here. This is a model of the cetuximab molecule. So it's a mouse-human hybrid antibody that is developed in a murine myeloma cell line. And they were able to demonstrate during the New England Journal study that the patients who were reacting to cetuximab were actually making antibody to the FAB portion of the molecule. So they said that that means one of two things. They were either reacting to a murine amino acid sequence, or they were reacting to a post-translational glycosylation molecule. And they looked, it's such a cool study. I wish I could tell you the whole study, but basically they showed that they looked at these patients to see if they also had preformed antibody to other monoclonal antibodies that were developed from mice. And when they did not, they were more suspicious that it was one of these post-translational oligosaccharides. They were able to show that the patients in the study were also forming antibodies to other mammals. So this was from a mouse, but they were also showing IgE antibody to cat and dog. So they started to think that their trigger might be this alpha-gal. I'm sorry, I don't have a very good speaking voice. So what exactly is alpha-gal? It is a carbohydrate that's synthesized by the glycosylation enzyme alpha-1,3-galactosyltransferase. And interestingly enough, that enzyme is present in this murine myeloma cell line. ImClone also made a version of cetuximab that was developed in Chinese hamster ovary. Those cells did not express alpha-1,3-galactosyltransferase. And interestingly enough, when they looked to see if the patients were making antibodies against the cetuximab that was developed in the Chinese hamster ovary line, they were not. The alpha-gal epitope is present on the tissues and cells of all lower mammals. Humans, apes, old world monkeys do not have alpha-gal due to an inactive gene product. So from this fantastic New England Journal study, they started to suspect that that people who were allergic to cetuximab may also be having issues with mammalian meat. Contained within that New England Journal paper were 6 patients out of UVA who presented with recurrent idiopathic hives or anaphylaxis, and they were able to demonstrate that they were making antibody against cetuximab, and they were demonstrating antibody as well, IgE antibody against cat and dog, not often against major cat allergen, which is what we typically see as allergists. When someone tests positive to cat allergy, they're usually making the antibody against FeLD1, which is a cat protein. So these patients were making antibodies against cat and dog, but not against FeLD1, with the exception of one patient who probably really was allergic to cats. And they were showing high levels of IgE antibody to beef. The reason they were actually looking at this is because a number of the patients who were presenting with these idiopathic hives or anaphylactic reactions suspected that their reactions were being triggered by meat. So they started looking into it a little bit further. And the UVA guys published this great study in the Journal of Allergy and Clinical Immunology in February of 2009. In this study, they looked at 24 patients based out of Virginia and Missouri who were reporting symptoms of hives, angioedema, or anaphylaxis that was occurring 3 to 6 hours after eating mammalian meat, in spite of negative prick skin testing to those foods. This is, I don't know if this is projecting well, but these are skin tests from the actual study. This is a study patient. And just so you know, I'll give you a little allergy background. This is how we diagnose food allergy in the allergy world. Prick skin testing, very reliable, very low incidence of false negative rates in general. But this was a patient who was clearly giving a clinical history of reacting 3 to 6 hours after mammalian meat. And as you can see, they have a good positive control. And very slight, you could argue maybe that the beef, lamb, and pork are slightly larger than the chicken, the turkey, the fish. Cat and dog, slightly larger, they're mammals, but nothing clearly positive. However, when they did intradermal testing to foods, which in general we frown upon in the allergy world, because it tends to, number one, overcall food allergy, and number two, it can be risky if you're injecting allergen under the skin in someone who's got a food allergy. But in the case of this study, they were able to demonstrate that this same patient, when tested intradermally, had clear positive tests to the beef, pork, and lamb, negative to chicken, turkey, and mite. These are 13 of the patients from the study. You can see they're adult patients ranging in age from 20s to 80. Whoops. All of their alpha-gal titers were, IgE titers were elevated. And as you can see, there's a huge range here. And these are all reactive patients. These are not just patients with a positive test. These are patients with a clinical history of reaction. So you can see this patient's alpha-gal IgE was very low at 0.52. And there were a couple patients in the study whose titer was greater than 100. The other thing that was interesting about the study was that consistently they were reporting a delay in the onset of symptoms from when they had the exposure to the meat. This breaks down in the patients who were reactive in this study, specific IgE antibodies to different allergens. Okay, anything below this line was considered undetectable IgE antibody, and they report them by number. But you can see the patients who were reactive had, on average, very high levels of alpha-gal IgE antibody. They also were high to beef, pork, and lamb, but almost none of them showed antibodies to non-mammalian meats, poultry, or fish. And similarly, the mammals, cat and dog, were elevated, whereas major cat allergen, FeLD1, was much lower. So this was a really, really interesting study because they were basically defining a new food allergy with characteristics that were very different from food allergies as we have known them in the past. So patients previously tolerating meat suddenly developing an allergy to a food that in the past was never considered a major food allergen. And the other thing that was very unusual about this was the delay in the onset of symptoms from exposure. So this generated some further questions for these guys. First of all, they were wondering, is this just a local regional issue, and is it relevant to a greater population than these 24 patients who came to our clinic? They were wondering why patients were suddenly generating this IgE antibody to alpha-gal. And they wanted to explore the delay and why the delay, because it's so different from everything we've ever learned as allergists. This is just a quick study that I wanted to mention. This is from the same group. They wanted to look at whether or not this sudden development of alpha-gal IgE antibody also increased risk for other atopic diseases such as asthma. So there's a strong link between IgE antibody and specific IgE antibody to certain allergens and the development of atopic diseases like asthma. Interestingly, they showed that this was a group of patients that presented with either idiopathic anaphylaxis or idiopathic hives in their study. And you can see that irrespective of whether they had a cat in the home or no cat in the home, the vast majority of them were showing some level of alpha-gal specific IgE. They had two control groups in the study. One was a group of patients presenting with asthma, and another was a group of just random patients coming to the clinic, not for hives or anaphylaxis, not for asthma, but for a different concern. And you can see that there's a much lower incidence of alpha-gal specific IgE in those groups. But the main slide I wanted to show from this study was that they also demonstrated in this study that as alpha-gal specific IgE increased, there was a tandem increase in total serum IgE. And that was regardless of whether it was low or high. As one went up, the other tended to go up. And some patients showed that as much as 30% of their total serum IgE was made up of alpha-gal specific IgE. And if they were able to remove that alpha-gal specific IgE from the circulation, the total serum IgE dropped in tandem with that. So there was clearly, in these patients who were reacting to meat, a significant proportion of this elevated IgE was made up of the actual alpha-gal specific IgE. They published another study in 2011 in Pediatrics looking at the same question in children, and the findings were very similar. They looked at 45 kids ranging in age from 4 to 17, and patients were presenting with anaphylaxis in 44%, gastrointestinal symptoms in 64%, hives or skin symptoms in 92%. And again, they saw this delay of, on average, 4.68 hours. 100% of them reported exposure to a tick bite. And again, this is very similar to the other slide I showed you, but oops, you can see that elevated alpha-gal IgE, elevated to dog and cat, but not FeLD1, elevated to pork, beef, and milk, but not allergens that are non-primate, that are from non-primate mammals. So the next cool part of this whole story is how they made the link to the tick bite as the cause of this allergy. They first noticed that these cetuximab reactions were occurring in a very limited geographical distribution of these 5 states. So they started thinking about what regional aeroallergens, regional parasites, regional fungi are found primarily in these states. And as you can see, this is a map of the, this is back from the 2011 Jackie paper, but this is a map of showing the number of alpha-gal cases reported. And you can see the patients who were reacted to cetuximab and the patients who were reacting to meat had a very similar distribution. They noticed that the map of the cetuximab reactions and the alpha-gal reactions were very similar to this map from the CDC showing the geographical incidence rates of Rocky Mountain spotted fever, which is a tick-borne disease, as I'm sure you all know. And you can see, I mean, the ones with the highest incidence are these red ones, and the orange is the second highest. You can see it follows a very similar pattern. Additionally, some of the patients in the trials were reporting that they suspected that the tick bites might have been the trigger. A couple of the patients said, I could eat meat, then I had tick bites, and then I started having reactions to meat. This is from 2010. This was data from the CDC website showing the distribution or the range of the Lone Star tick. And this is an updated slide that was last updated in February of 2014. So the range is expanding, and as you can see, there we are in yellow. And there's our tick friends. Lone Star tick is here. And just a couple points I want to make about this slide. One is that, I'm sure all of you know this, but just because the tick doesn't have a white dot on its back does not mean it's not the Lone Star tick, okay? Lone Star tick is a very aggressive species of tick. It feeds on the human host in all stages of its life cycle. That's what the little sad faces are for, okay? So the black-legged tick and the American dog tick do not feed on human host in the larval form, okay? Lone Star tick feeds on a human host in all stages of its life cycle, and it is in fact this larval form that gets misrecognized as trigger bites, okay? Those bites happen consistently in the late fall, in the late summer, early fall, which is when the larvae are active. And we know that I know that they're trigger bites because they cause this out. I know that they're Lone Star tick bites because they induce this allergy very predictably. But the other important point to make is that patients need to know that just because a tick is small and it bit them does not mean it's a black-legged tick, because, unless you're looking, and this is a dime, so unless you're really examining these ticks, or you're very well trained in recognizing different ticks, I mean, it would be very hard to distinguish between these different tick species. So patients can't assume that it was a black-legged tick just because it was small. when they were making this tick, I'm sorry, the colors are not projecting very well. Some of these are actually red, and some of these are actually black. And most of the red ones are up here, okay? Just trust me on this. What they're showing here, this was from the tick paper. They did a bunch of surveys on patients in their clinic regarding history of tick bites and history of reactions to meat. And what they showed was that it was more likely for patients to report history of tick or chigger bites if they had elevated specific IgE for alpha-gal and an elevated total IgE. In patients where no history for tick bites were obtained, or patients who actually specifically denied tick bites, you know, the total IgE ranged across the board, but they were not showing a lot of IgE to alpha-gal. So it seems the patients with tick bites were more likely to show positive antibody against alpha-gal. So indirect evidence, but certainly compelling. Sorry. Another interesting thing in the survey was that one of the questions they asked was, do you tend to get prolonged itching after a tick bite? And many of the patients who had positive alpha-gal antibodies reported that after a tick bite, they would have redness, swelling, and itching that lingered for months for many of the patients. So they tended to have more severe local reactions and more prolonged local reactions to the tick bites. This was another piece of the study. They broke down the Lone Star tick. They mortar and pestle crushed it and broke it down into its different proteins and tested patients for antibodies to alpha-gal as well as IgE antibodies to the different tick proteins. And you can see the trend. As there was an increase in alpha-gal specific IgE, there was also an increase in antibodies to other tick proteins. And the icing on the cake was that they had 3 patients that they were following initially as control patients who they had serums prior to a history of any tick bites. They were all alpha-gal negative at the start of the study. And then during the course of the study, they reported documented episodes of multiple Lone Star tick bites. And so this is sort of a small slide, but the top line is the changes in the total serum IgE. The bottom line is the changes in alpha-gal specific IgE, and the arrows are the tick bites. So in this patient, they report tick bites here, and then tick bites here, and as you can see, both the total serum IgE and the alpha-gal IgE increased following those tick bites. This star is an episode of actually developing hives after mammalian meat, even though this patient had previously been able to eat meat without issue. And then you see that the levels start to trend down, and then another Lone Star tick bite, and everything goes back up again. You see a similar picture with this patient. You know, the tick bites are the arrows, everything goes up, they start to come back down, they get another tick bite, everything goes back up, and here they react. This third patient had tick bites, and they do see a bump in their total serum IgE, and they had a slight bump in their alpha-gal IgE. In this particular patient, the alpha-gal IgE made up only about 1% of the total serum IgE, and they never became clinically reactive to meat. Okay, which is an important point I want to make later. This patient did have a positive alpha-gal IgE test after the tick bites, never reacted to meat. Okay, but in these patients, they did demonstrate pretty clearly that the tick bites induced the IgE elevation. So the next question is, why the delay? As I mentioned before, despite these patients in many cases having very high titer IgE antibodies to alpha-gal, to beef, to pork and lamb, they were not aware of any immediate response while they were eating the meat. If you've ever seen a food allergy patient, a peanut allergic child or a shellfish allergic person, almost universally the first thing they'll report is feeling itching, tingling in their mouth, lips, and throat. These patients denied that completely. They'd be completely 100% fine until at least 3 hours out, where they develop relatively rapid onset of symptoms of anaphylaxis. And we talked about that. And I mentioned this, I'm just reinforcing it. There's really, prior to the discovery of this allergy, You can read any allergy literature you want. There's never been a documented case of a food allergy reaction happening further than 2 hours out from an exposure. And in most cases, the reactions are happening within minutes of exposure. So this is very atypical. I'd like to put in this slide, this is an interview with John Grisham, the author. He lives in Charlottesville, or that's where he does all of his writing. And they did this interview in this paper in 2011, and as you can see, I pulled this out here. They asked him, does he have any favorite dishes? And he said, I have this weird food allergy that started about 5 years ago. So I can't eat beef or pork, which is probably pretty healthy. We eat a lot of fish and fowl. I'd kill for a cheeseburger, though, or a big steak. At UVA, they were so confounded by these patients consistently reporting this delay in symptoms that they decided to prove it. So they brought in a few patients with a history of reactions to meat and positive alpha-gal testing, and they did some challenges. This patient had an alpha-gal IgE of 30.3 and a total IgE of 146. This is before the challenge. She looks pretty clear. I don't know how well this is projecting, but this is 3 hours and 45 minutes after they fed her a couple of sausage patties from McDonald's. And she's got extreme palmar erythema right here. I'm sorry that these are not projecting very well. Here's another one, given meat, and this is showing diffuse urticaria that developed on the patient's arm at 4 hours and 15 minutes after the meat ingestion. And here's a third challenge. This guy ate his sausage patties, and 4 hours and 25 minutes after eating, he developed pruritus, and this urticarial outbreak started on his right flank. So the actual challenges were supporting the clinical history of these patients, that these reactions were delayed. So they were trying to figure out the reason for the delay, and their suspicion was it has to do with the fat. It's very clear when you see a lot of these patients that the fattier the meat, the more likely a patient is to react. We don't know why, but it does seem that it's the fat absorption that's triggering the reaction. So without getting into the detailed biochemistry of the reaction, suffice it to say that the deliver of lipid to the circulation takes about 4 hours. So if fats are processed very differently from carbohydrates or proteins. You'll remember the bile acids and the pancreatic lipase. They have to form micelles. They go into the brush border of the small intestine, and they get packaged into these chylomicrons, and they go into the lymphatics. And the whole process, before it gets into the bloodstream, takes a while. On these chylomicrons, there's actually the alpha-gal is expressed on the surface of these chylomicrons, among other cells in the mammal. I'm almost done with the science stuff, and then we're going to talk practical. But I wanted to mention this because it is very clinically relevant. Gelatin is derived from beef and pork collagen. Okay? So patients with alpha-gal allergy can also be allergic to gelatin, and it's something that I see not uncommonly. They looked in Jackie in 2012, they looked at 1,335 subjects who presented with a history of suspected anaphylaxis, either to foods or drugs or idiopathic. 40 of those 1,335 subjects did have a positive skin prick test to colloidal gelatin. Of those 40, 30 of them also had a history of meat allergy and showed that they tested positive for alpha-gal IgE. So gelatin allergy is not that common, but in patients with gelatin allergy, they showed that a good percentage of the patients with gelatin allergy actually are alpha-gal allergic. 12 of the patients who tested positive to alpha-gal and gelatin actually not only reacted to meat, but also gave a history of actual true clinical reactions after ingestion of gelatin. And the last study I want to just mention quickly was this study that came out in the Allergy Journal in 2013 out of Sweden. this group was able to demonstrate the presence of alpha-gal allergen in the GI tract of this Ixodes tick. It's interesting because alpha-gal allergy is not unique to the United States. There are cases reported in other areas of the world where ticks are prevalent, and in different countries, it seems to be different ticks trigger the allergic reaction. But in this study, they looked at 5 patients as well as 5 patients with a history of meat allergy reactions, as well as a control. Here they did an immunoblot showing the 5 patients' serums binding to different proteins from this tick. They did it first before they incubated with alpha-gal, and then they incubated the serums with alpha-gal, and you can see in at least 2 of the patients, they had less binding after their serums were incubated with alpha-gal, suggesting that the tick has actual alpha-gal protein expressed. Then they took the patient's serums and they incubated with serial dilutions of Ixodes tick extract, and you can see as they increased the percentage of tick extract, the alpha-gal IgE went down, whereas in the control, there was no change. They then did some, these are just so bad. Just trust me. These are cross sections of the tick. This was stained with patient's alpha-gal positive patient serum, and you can see that the alpha-gal bound to the GI tract in the tick. And this was just a mouse monoclonal antibody specific for alpha-gal. And again, you can see binding and staining here in the GI tract of this tick. And these were controls, alpha-gal negative patients, and you don't see that staining. And this was a mouse monoclonal antibody that was specific for FeLD1, and you don't see any staining in the GI tract. So they were able to show that at least in this tick, alpha-gal is present in the GI tract. So they hypothesized that the actual allergen is being introduced upon tick bite, and that's inducing the reaction in susceptible individuals. I want to change gears a little bit and just tell you a little bit about my alpha-gal experience. The first case I identified was in October of 2011, and since that time I've diagnosed 239 cases. Probably will increase exponentially in the near future when this snow finally goes away. Prior to the cases I diagnosed, no cases had been reported on Long Island. I've collected data on all my patients, but I've really sat down and analyzed it at least on my first 100. The age range of those first 100 patients range anywhere from as young as 5 up to age 87, with an average age of about 48 years. Pretty evenly divided between males and females. And consistent with Scott Cummins' data, the range of alpha-gal IgE in clinically symptomatic patients is broad, okay? As is the range of total serum IgE. You know, some patients were very low while other patients were very high. 12 of my first 100 patients were under 18 at the time of presentation. I want to talk a little about the practical stuff, because this is probably what you really need to know when you're seeing patients in the office. Very important to be aware that the vast majority of cases are going to present in the middle of the night, which makes sense. People tend to eat their biggest meat meal at dinner time, and with the 3 to 6 hour delay, most people are going to be waking up 1, 2 in the morning having these reactions. Dr. Cummins gave me some slides, and he called his talk Midnight Anaphylaxis. And I stole it, and I used that title as much as I could, and I kind of used it out, so I had to change my title, but it's a good name for it. So anytime you see a patient who's coming in saying they're waking up in the middle of the night with an allergic reaction, you better prove that it's not this. Most common presenting symptoms, about 90% of the patients present with skin symptoms. Most often it'll start with the palms and the soles of the feet, or the ears. They'll start with intense itching, and it will progress with hives and or flushing that can be localized or generalized. The next most common symptom that we see is actually gastrointestinal symptoms. Okay, it's very common for patients to complain of severe abdominal pain, cramping, nausea, vomiting, diarrhea. See these in about at least 60% of the patients. Cardiovascular symptoms are not uncommon. 30 to 40% of the patients will report feeling lightheaded, and I definitely have a good number of patients who actually lose consciousness. And then respiratory symptoms also, again, about 30 to 40% of the patients will report respiratory symptoms, either involving the throat or involving the chest. And then every once in a while you get the odd, rare case. I've got a couple patients that present just with angioedema. One guy I take care of had been getting episodes of angioedema of the throat a couple times a week for many years. No other symptoms. And he was a pretty regular meat eater, so it took me a while to figure out what was going on, but he had a clearly positive alpha-gal test, and when he removed mammalian meat from his diet, the episodes went away. History of adult or larval Lone Star tick bites is frequently elicited, and that's really important to ask. Because if you just say, have you had any Lone Star tick bites, the patient may say no, especially because people get confused with ticks and chiggers. You also have to say, well, have you had any chigger bites? And then you teach them that they're not really chiggers, but you have to ask about the chigger bites, because if you don't ask, you're not going to get that history. People don't think they're ticks, so they're not going to give that history. It's important to note that many patients with the allergy can tolerate some meat. As I said before, the fattier the meat, the more likely they are to have a reaction. So just because a patient says, no, I ate, roast beef for dinner last night, does not exclude this allergy if they have had reactions after meat. Okay, additionally, the further you go out from a tick bite, from a Lone Star tick bite, the less reactive you become. So if somebody said in September, 3 weeks after I had chigger bites, I ate a burger and I woke up in the middle of the night covered in hives, but now I'm eating a burger and I'm fine, that doesn't mean it was not alpha-gal allergy. An important point I want to make is that most alpha-gal patients, in spite of a positive test for dairy, eat it just fine. So we do not routinely tell people to avoid dairy. I'd say only about 3% of my 239 patients have any issues with dairy. It is not really very clinically relevant, so I would not advise patients to take dairy out of their diet if they test positive to alpha-gal. Another point that I think is important that I want to make is that some unpublished data out of UVA, along with my own clinical experience, suggests that patients can test positive to alpha-gal and not have any clinical reactivity to meat. Okay, so what this, I don't know. I don't know whether it's a true false positive or whether I would call it a subclinical positive. But the fact is, if patients get Lone Star tick bites, there's a good chance that they're going to at least transiently make some antibody, alpha-gal IgE antibody. Scott Cummins down at UVA is looking at a group of arborists, okay, who are constantly out in the woods, who are constantly getting tick bites, and following them and getting regular alpha-gal IgE levels regardless of whether they're eating meat or not. And he's showing that almost all of them, at least at one point or another, are showing positive tests for alpha-gal IgE. And the vast majority of them are eating meat fine. So because of this, I would not recommend routine screening for alpha-gal allergy. I know out here it's our instinct to make sure that we're taking care of our tick patients, that we're looking for every possible tick-borne disease anytime someone comes in with a tick bite. It actually muddies the water a lot if you send an alpha-gal test on any patient who comes in with a tick bite, because potentially what we're going to end up doing is restricting a lot of people who really probably don't need to avoid eating meat. My son had a tick bite, a Lone Star tick bite last summer. I didn't bother to test him for alpha-gal. I didn't want to know. I just watched him for a little while. I maybe had him go light on the meat for a couple of weeks, and then I let him eat it, and he's been fine. I've had Lone Star tick bites. I don't test myself for alpha-gal allergy. It's good to have a high index for suspicion, but only if the clinical history is compelling for this allergy, okay? And the last practical point I want to ask you frontline doctors about is that it's very helpful to me when you send an alpha-gal IgE, because then when I see the patient, I know that it's a true positive, and we can talk about it and I can counsel them. if you're going to send an alpha-gal IgE, please send a total serum IgE. Because they showed in some of the earlier slides, the greater the percentage of your total IgE that's made up of alpha-gal IgE, the more likely you are to be truly clinically sensitive. And when I follow these patients over time to see if they can eventually reintroduce meat, because many of them can and do, that ratio is probably one of the biggest factors in my decision making. So this is it. In summary, evidence suggests that Lone Star tick bites can affect both total and specific IgE levels in some patients. In many cases, the sensitization to alpha-gal appears to decrease over time, but additional Lone Star tick bites may lead to a more significant increase in the IgE response. So it's a very fluctuating allergy. It's not a static allergy. It's not like a peanut allergy, like you have it, you have it. And just that it's probably induced by the presence of the allergen in the tick's GI tract. And that's it.